Alrighty, we're going to talk about reactive behaviors, and mostly we call them behaviors down here, but in Canada they actually call them reactive behaviors because when a person with neurocognitive disorder, dementia, we have to call it neurocognitive disorders now, anyway, begins doing something, hitting, slapping, kicking, biting, wandering, pacing, whatever, they're reacting to something, either an internal or external stim trigger that's causing them to do something. And so I think if you have that as your premise, it can help you figure out, okay, now what do I do to get that to stop? What can we do to make that not happen? And before I go any further, I wanted to say one of the reasons for incontinence in men, I'm pointing at you, not that you're incontinent and you're a man. However, you did ask a question, came up on break, do men become incontinent for any other reason than their prostate? And I was thinking, well, no, and then it dawned on me, well, duh. Yes, dementia actually causes incontinence, more of a functional cognitive reason for incontinence. They can't remember where the bathroom is. Usually starts with voiding or peeing in inappropriate places, almost always the sink in care communities, outdoors, wherever. Ends up, then they just can't trigger their brain, tell their body, I need to pee, get up and go to the bathroom. What's ringing? Oh, it's her. Okay. Alrighty. I'm hearing things. All right. First thing you need to know is there's different types of dementia. Okay? We always say Alzheimer's, and we really should stop doing that because Alzheimer's looks different than all the rest. What is a neurocognitive? Definitely significant problems in multiple domains of the brain. So you need to have difficulty with memory. That's the easy one. You need to have difficulty with sequencing. Like the reason you all got here this morning on time is because your brain was able to do this great little sequencing thing. Said I had to get up at X time to have my breakfast, to have my shower. Awesome. To drive here, to get here on time. And your brain was able to do that whole sequential thing because you don't have dementia yet. Okay. And, insight, judgment, rational thinking, all those different domains. So you have to have a significant decline in more than one domain. Language, motor skills, executive function, memory. I'm just kind of breezing through this because I want to get to what counts. We're going to go through 4 or 5 different dementias very quickly, but you can stop me if you need to. Just so you can see how they're different, and when you're trying to get them to do something or not do something, it's completely different plans of care. So we'll start with Alzheimer's because it's still the most popular. They estimate about 60%, used to be 90% before we knew better, 60% of all types of dementia or neurocognitive disorders are Alzheimer's. Alzheimer's is very distinct. It's neurofibrillary tangles in the brain and some plaques up there, and it's jumping around, and it progresses differently than all the rest. I like to call them Energizer bunnies. If you write that, and that's all you know about Alzheimer's, if they're sitting doing nothing, they don't have Alzheimer's. Energizer bunnies, they are moving. They're moving and walking until the last few months of life. Okay? They're not in wheelchairs unless they have some other disease. Moving and walking to the last few months of life. You have problems with weight loss because on average, so an average diet is 2,000 calories per day for the average American diet. They need anywhere from 4,000 to 6,000 calories a day because they're moving that much. They're constantly exploring. They're visually triggered. Have door, open door, see door. See chair, push chair. See table, push table. Wires, play, move. They remind me of 2-year-olds or 1 to 2-year-olds when they begin to learn to walk and start exploring. So does a 2-year-old lie in bed in the morning and think to himself, you know what, doggone it, today I am getting down. I'm going to open that sucker up. I'm going to pull the Clorox out, take that cute little blue top off and kick me back some Clorox. Does a 2-year-old do that? No. How come 2-year-olds drink Clorox, given the opportunity? They're visually triggered. They get out of bed, they're wandering along, they see they're in the kitchen, they're eye level to the cabinet under the sink. It's the only reason they want it. If they're eye level to a door handle, they'll open the door, but they're eye level to that, so they open it, they see a bottle, it's cool, they'll play, and they're oral, so they'll kick it back. Alzheimer's is exactly the same. That's why all memory care communities start out with these beautiful paths. You go in one door, out around a path in another. You want them to walk and go and do. Visually triggered. Awesome. Simple. If they're having a problem behavior, you just walk with them, take them where you want them to go, do something for 90 seconds, and they've forgotten whatever was. Memory prompting does not help, ever. George, I just told you dinner's in 10 minutes. George, your wife isn't coming till tomorrow. George, you're married, for God's sake. Get on with it. No, nothing. Never going to work. Nothing. No memory. No short-term memory. Long-term memory sketchy. Memory's poor. Word finding, difficult. Word finding problems happen early in the disease, mid-disease. Their sentence structure isn't great. They might have a few sentences tucked away in their pockets, but mostly they're having a hard time formulating sentences and paragraphs and full thoughts by mid or definitely by late. Drugs for Aricept, Razidine, Exelon are all the cholinesterase inhibitors. They've been around forever. Side effects are weight loss. Let's give them to Alzheimer's, who's losing weight. Awesome. Good. If weight loss is significant, you switch from any of those to the Exelon patch to bypass the gut. Helps sometimes. Namenda, the newer kid, memantine, works synergistically. I've heard people in care communities and many physicians believe, oh, I stop Aricept and I start Namenda. No, together is better. Namenda is for mid-disease, mid to late. You bring it on. Aricept's early, straight through. You keep them until they are functionally needing hands-on assistance. You keep them until they need total care with toileting and showering. If they are helping at all, the drugs are working. Their claim to fame, the only thing they do is allow care partners to assist them into the bathroom, to be toileted, to get dressed, to maintain the ability to do those skills with minimum assistance. If they can't do them at all, the drugs have done their business.
Did I hear you say that you shouldn't run on any of those drugs unless they're diagnosed with Alzheimer's, or you're also using them for dementia?
Oh, I didn't say anything about any of that, but I'll go there if you want to. I mean, if you want to just get onto it. The drugs, okay, well, there was 5 questions in there I got to pull apart. Number 1, these medications are for Alzheimer's. They're also used for other types of dementia. Alzheimer's is a type of dementia, right? So dementia or neurocognitive disorders, a classification of all diseases that affect cognition in more than one domain. So people get this confused and I forget because I always think we're over it, but we never are. My mother, thank God my mother has dementia. She doesn't have Alzheimer's. Okay, no. She may have Alzheimer's, she may not. They think dementia is a disease unto itself. It's not. All it is a classification. So if you say you have dementia, your next question to them has to be what type. Just like if I told you I have cancer, your next question is where, Liz? And if I told you I had skin cancer and I'm going to have that taken off tomorrow, you'd be like, so we're sharing why? Versus I have liver cancer with metastasis to the brain, bye-bye, I got 6 months to live. Both cancer, both abnormal cell growth. You can see completely different treatment, completely different prognosis, completely different plans of care. That's why we have to figure out the type of dementia, the neurocognitive disorder. So, that's what I said first. Second, these medications the Aricept, Razodine, and Exelon are started right off the bat. The minute you think you have the diagnosis of Alzheimer's. Now I'm going to say think, because the only way we know for absolute certain is upon death if we do a brain autopsy. We have a pretty good idea that they have Alzheimer's because of the way the family describes how it started, the word finding, the concentration. They're getting lost because they're visually following roads that they shouldn't be. They're losing weight, maybe, all those kind of things. Looks different than other types of dementia. When I diagnose, and I have a clinic one day a week that I see community peeps and get consults from docs, when I diagnose, I always say, this is going to be my working diagnosis. I'm going to say Alzheimer's because it looks like it. But I have to watch you for a couple of years before I'm going to hang my hat on it. A couple of years, and they're like, well, a lot of good seeing you is. Fine specialists you are. It's like we don't have anything. We don't have anything better than that. And if they tell you Alzheimer's and they hang their hat on it with one visit, don't believe them. They might get lucky, 60% chance of being right. What was your, did you have another question on that? Am I dreaming?
Well, you know I do, and then I'll stop.
Okay, no.
But I am doing this med administration, so I'm wondering, do you titrate? I mean, I know the members titrated up, and are you stopping the Aricept?
No.
Or titrating down?
They're synergistic. They're together, always together. Aricept and Namenda with one of those, always. Together is better. Together, 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 together for Alzheimer's. For Alzheimer's. And what's happened with Aricept, Exelon, Razodine, that class of cholinesterase inhibitors is they have worked so well, which is what Medicare has given so much money. NIA has given so much money to the research of dementia. And these drugs, their only claim to fame is to delay progression of functional loss, is to maintain functional ability longer. And what we know is people that take them will enter a care community 6 to 12 months later than people that don't take them. Which you're thinking 6 months, big deal. Huge financial deal for Medicaid and Medicare and for Americans. So that's why we use them as soon as we can to delay placement. And that's also why people in memory care and foster homes and all the rest are getting people more frail than they used to. Used to get walkie-talkies. Well, I don't get as many walkie-talkies because they're still continent. They're still dressing. They're still doing okay. Their disease is progressing right along, but they're functionally able to be managed at home longer. Versus vascular dementia. These two are like diametrically opposed.
Can you just speak about the antipsychotics just quickly?
I'm going to tie it in a minute. I promise. We're going to be here till 4. Okay. So, vascular dementia, couch potatoes. Alzheimer's is what? Energizer bunny. Vascular couch potatoes. The problem with the vascular brain, it's a subcortical dementia, deeper part of the brain. The part of the brain that's the get up and go. The part of the brain that got you here this morning on time, that can plan and sequence. Now, Alzheimer's, I don't know what they're doing, but they're moving around, they're up, they're taking things. These folks can't even get up and go. They have profound apathy. They get accused of being lazy. They get accused of being depressed. If they break their hip, rehab PTPs hate them because they don't try. It has nothing to do with it. They can't. They can't get up. Come on, let's go to the bathroom. You want to go? It's been a while. You want to go to the restroom? You want to go? No. Favorite word, no. Put that there too. No. No. They mean it. No means I have no clue what you want me to do. I can't begin to do it. I don't know how to get from A to B. The approach with these guys is you have to be a cheerleader. And you can imagine how much families love being a cheerleader, especially spouses. You can take instruction from your spouse so well. These are the ones, can I know your name?
Mine?
Yeah.
Pat?
These are the ones you have to say, Pat! Hey! Pat! Oh my God, Pat! Look at you! Look at you! Oh my, I have, you know what? I got cookies. Oh yeah. I have to pounce on Pat, because she has vascular dementia, she doesn't know it, to get her to come with me. I have to do nothing. With Alzheimer's, I have to, hey, I have to start walking, they'll follow. I just have to do something goofy, and they're coming. I don't care. I can get them out of trouble in a second. Vascular, they will sit and wet themselves on the couch, and the caregiver will have a fit. I asked them. And the reason you don't just say, well, they have vascular dementia, yeah, because we don't get mad when Alzheimer's people wet themselves. We really don't. But vascular, we get really ticked at because they have preserved verbal skills. They do not have word finding problems. They have great communication. Oh, so sad. They can lay you out. They can find memories. Alzheimer's can never find them. I can never say, do you remember Alzheimer's? Vascular, I can say, Liz, you remember your daughter was here yesterday? No. She had the white shirt on with the red jeans? Maybe. She brought cookies? Got it. Oh yeah, the oatmeal cookies with raisins in them, and my granddaughter came with her, and we read the newspaper together, and we went for a walk, and then we went shopping, and then we did, and it'll be absolutely right. You kickstart vascular to complete the story. You have to help them find the memory. They have a retrieval problem. Once they retrieve, once they hit it, they're there. They go with you. They're fine. But you have to find it for them. It's why when they go to doctor's appointments, they fool everybody. The trigger is the doctor. They walk in, they see the lab coat, or they see the lobby, they see registration, they see walking down the hall, they see nurse, they see blood pressure. They're on, they know exactly what to do then. Oh, and if they've had the same doc for a long time, they say, oh, and how are your kids? Did they end up going skiing last winter when we talked about that? Or, yeah, you know, hey, and how long have you been in this new office? It doesn't matter. They will trigger and say the right thing. And how are you feeling? I'm feeling very good today. And we drove here from blah, and blah, blah, blah. And the doc's looking at the daughter like, this one is not demented. Are you insane? She's fine. Look at those verbal skills. They will do really well on the MOCA, which is replace the mini-mental. So the Montreal Cognitive Assessment, or the SLUMS is another one. Do really well on a lot of it. They'll have problems with the visual spatial and the concentration part. They'll have great language fluency. They'll even have fairly good recall. And they'll definitely, if you give them one clue, they'll recall 100%. If you put a word in the category, they'll pick the right one out. So you can see they drive you crazy, and you treat them completely different than Alzheimer's. So a lot of times why caregivers are getting upset is they only have one tool for all demented peeps, but they need to know what type of dementia they're working with. Some things that help, you put them on Memantine or Namenda because everybody wants to. Yeah, it works a little bit. But usually I have to give them something to jack them up. Their problem is initiation. Get up and go. So I'm going to start with the serotonin uptake inhibitor, SSRIs, Prozac, Zoloft, Lexapro. One of those, because they wake you up. They're antidepressants that wake you up. They increase serotonin, which is the go. Or I'm going to then switch to Ritalin, which Ritalin, for real people that don't have, you know, ADD or whatever, is a stimulant. And I'm definitely not going to deny them 100 cups of coffee a day. I want caffeine. I want everything I can get on board to get them to go. Now, if they have a arrhythmia and they can't have caffeine, I'm stuck not using that. Other than that, caffeine's good. Was there a hand there?
Yeah, that's fine. Because of the fact that vascular dementias, like I work in a physical rehabilitation facility, and it's a skilled nursing facility, and I mean half the clients that we have don't want to get up and do therapy, and they have some memory loss that could be contributed to just aging. How would you, I mean, it seems like vascular dementia would be almost impossible to diagnose without knowing them long term.
Right, you can never diagnose dementia short term. People that come out of the hospital with a diagnosis of dementia, you got to throw it out the window because it's delirium until proved otherwise, post-hospital delirium. The way I would get, I did a subacute program for a number of years, so the way I would get my hip fractures or, coming in there just for not really learn to walk again, but to just get strength back after their pneumonia or whatever, is I put them all on an antidepressant, even for a short time. So put them all on an SSRI unless for some reason they can't take it. It helps stimulate, because no matter what, they're depressed. Even if I'm not treating vascular, they're depressed if they're in rehab. I know you think it's fun. They think it's depressing. Oh my God, how did my life end up here in a nursing home rehab? I don't care what we call it. They call it nursing home because it looks like a nursing home, no matter how classy it is. And not putting them down at all. This is the consumer's perspective is, oh my God, I had to go to that nursing home. They are feeling older than old. So I put them on an antidepressant. I'd ask whoever their prescriber is to get that going. The other is I would put music in the doggone rehab place. Music bypasses every other part of the brain and gets people going. It at least gets them to tap. And if I'm going to ask somebody to walk who's 90, well, doggone it, I better have something that really pops. It can't be classical. It's got to be something that pops, that's really going to get them going. I don't know what it is, Motown, rock and roll. We can get all kinds of good stuff now that baby boomers are sprinkled in there. You can do the Stones, you can really get anybody in there. And it doesn't matter, it doesn't have to be generational appropriate, it has to be rhythm appropriate. Anything but rap. They will move to. And they'll go. They don't know the words. So if you're using it for a therapeutic thing, for Alzheimer's or for memory reminiscence thing, you want to get age appropriate, generational appropriate. But if you want them to just move, you get music.
Why not rap if it's enough for Head American?
It doesn't have enough rhythm for going. And also, you're never sure when they're going to say something nasty that really get people upset. They just do. I can't help it. It's just the music does it. I like some rap. Close management of vascular disease is the treatment. So you don't, all the risk factors for heart disease, these, so they're on blood thinners, they're on blood pressure control, they're on statins, they're on all that stuff. Got it? Nailed it? Lewy body type dementia. Now, Lewy body looks like Parkinson's, like speed forward 20 years without having had Parkinson's. So the presentation Lewy body people have when they first start having problems and they go see their provider is that they're tripping. They're having coordination problems, and their care partner says, whoa, he's really not tracking right. She's really not tracking right. There's something going on. So two things are happening at once. There's sort of a coordination, functional problem. They look Parkinson. They're starting to be a little shuffly. With Parkinson folks, if I push them, which is really awesome to do. It's part of a real test you get to push. And things like, how's your trunk balance? So if I push you side to side, you shouldn't move. If I push your chest, I shouldn't fall backward. I should be able to hold it. You touch a Parkinson's and they have retropulsive instability. Bam. Do that. And Lewy body have it in times 10. So I can knock them over it's great. But I don't. You can try. They usually come with some sleep disorder. Usually REM sleep disorder. So they are having very dramatic dreams, very scary, aggressive. They have a hard time between sleep-wake. They usually aren't sleeping with their partner anymore because they're violent in their dreams. And that's been going on, predisposing the memory problems, you'll find. The hard part with this is when you test them cognitively, they have good days like solid rock stars and then horrid. And they're not consistent. So if you say you've assessed somebody for cognitive impairment once, you haven't assessed them for anything. You might have gotten a good day, and then they're dandy. I mean, really, they'll pass the test, and then the next day they won't. So it fluctuates. And here's where we're going to get to drugs. Way more likely to have hallucinations and delusions. So hallucinations are seeing, feeling, hearing, smelling things that aren't there. Delusions are beliefs in things that aren't real. The type that Lewy body get are disturbing. There's someone in the house with a knife that's going to kill me. Somebody's putting poison into my window. It's going to kill me. When Alzheimer's has hallucinations, just usually, they're the little kittens in the corner. They're the little puppies on the back of the couch. They're all the little babies. We love those. I think of Alzheimer's as, when they have hallucinations, as their imaginary friends. And we treat them, we tell the family, we'll treat them the same way. So for those kids that had imaginary friends, there's like 1 in, I don't know how many, 10 or 20, that have imaginary friends. What do parents do? If they're having cookies or something, Tommy gets one and then the imaginary friend gets a cookie, right? I mean, you don't just tell Tommy he's crazy. Tommy, you're psych. Come on. There's nobody there. Yes, there is. There's little Billy Boop, my best friend. So, Alzheimer's, no drugs. No antipsychotics. Unless they are really violent, they have a personality that's violent, they beat their wife once a week whether she needed it or not, they kicked the dog, they were violent, aggressive peeps. They are going to be violent, aggressive, demented peeps. They need drugs. It's the only way you're going to treat them. We're allowed to. Physical aggression, we can treat. We can sedate. Totally doable. Alzheimer's is not generally necessary unless there's a predisposing personality. Lewy body, pretty necessary to treat with antipsychotics, not because they're physically aggressive, but because their hallucinations and delusions are so scary, so upsetting, and they act on them. The only type of antipsychotic you can use with Lewy body is Seroquel. It's the only one that doesn't have a Parkinson's side effect. If you use Haldol or Zyprexa with Lewy body, they will start falling and progress quickly, and usually not be able to reverse that. So you all know if you use Haldol, they all end up Parkinson. They don't move, and that's not reversible frequently. With Lewy body, Aricept and the anticholinesterase inhibitors work to preserve speech. They work to preserve speech much longer, so they can have full sentences and talk. It's interesting, when you stop it, they stop talking almost. Keeps them a little bit more functional, but not much because they're having this coordination thing from a different part in their brain. Parkinson's, the only thing to say about Parkinson's is they had to have had Parkinson's for decades before they get demented. 80% of Parkinson patients, if they live long enough, will develop dementia. Really easy. Have you had Parkinson's for long? He's had it since he was 40. Okay, now he's got dementia. Hard to diagnose only because they can't talk anymore usually. They've lost their verbal. But they start doing weird things. They generally just need so much physical care. They end up in a care community. They need physical care because they're stiff and they're rigid and they're hard to move. And it's not that they're resisting you intentionally. They're resisting because their muscles resist. So they need a lot of hands-on care later in life when they start going to a care community. Cinemet, which is what they use all along, or L-Dopa and dopamine meds. becomes less effective as the disease progresses. The other problem with Sinemet is that its side effect is hallucinations. So you give them enough Sinemet to walk and move and not freeze, and they're seeing snakes. The type of hallucinations associated with Sinemet usually are like snake things and almost an illusion sometimes, like these cords here or something they misperceive as a snake. And when you have a hallucination like that, your brain kind of knows, oh, this is the drugs. It's like when you wake up from anesthesia, you know you're a little wacky. It's like, oh, it's the drugs. They kind of know that. And I've had patients say to me, look, Liz, I know I'm going to see bugs. I know I'm going to see snakes or whatever. My goal is to get out of the recliner by myself to go to the bathroom. That's it. I'll see bugs, snakes, I don't care. I want to get up by myself. And that's our deal. And yep, up at just a smidge, snakes come back. I'm like, really? Really? You can deal with snakes? Yep, I know I can talk myself out of it. Alcohol dementia caused by alcohol, of course, cough. You know, this disease, they've been drinking forever. They made it to old age somehow. My thought is, if you get to 60 or 70 and you have brain damage from alcohol, you were an amazing human being. Because mostly you die early if you're an alcoholic, mostly from other disease. You've been hit by a car, you've been found down, you freeze to death if you're over in this part of the world. Something happens. You're estranged from your whole family because they are not going to be able to do anymore. You have it's your social world that's going to cause you to die early. Now, if you make it to old age, you have to be incredibly charming. You have to just be such a fun person. You have to be a fun drunk that people will buy you alcohol, period. So, when they usually end up in a care community, they've been found down, they've been hit by a car or whatever, break something, go to rehab, they don't clear. They don't clear. So their delirium doesn't clear, and they say, okay, you have alcohol dementia probably. Probably. Always end everything with probably. Then they go to a care community and they continue to dry out. It can take a year to dry them out, to get them to their full cognitive level of what they're going to be. I have discharged 3 alcohol dementia patients from our memory care community because they dried out and they're fine. Now, one, the family was thrilled because he agreed to go to AA, and the other 2, the family wanted to shoot me. I can't keep him here against his will. He's competent. He's not demented. He's got to go. So, but all of them charming, lovely, do anything for you. Sure.
So is Korsakoff's like a reversible dementia?
No. What happens though is we don't know exactly when you're going to clear, when it's delirium, because we always find you down. You only enter healthcare because something else has happened. And then if you have surgery, you have anesthesia, and you have pain meds, and you have all the rest of it, which cloud the sensorium, so you get weirder. And you stop the alcohol, so you go through detox, and you get really weird, you get psychotic. So all these things happen, and you're old. So if you're old in America, you're demented. If you're young and have the exact same behaviors, you're detoxing. You're delirious. So it just takes a while. But truly, I have some that I haven't discharged that just, their service plan is so fun, you do it once, that's it. That's it. You never have to change. There's no progression of anything. It's normal age changes, but it never changes. Versus Alzheimer's, it's changing every quarter. They're declining. Nothing. It's great. Frontal temporal lobe dementia, sort of the newer kid on the block. The worst. If we're going to classify Alzheimer's, the best, the easiest. This one the worst, the hardest. Probably 3% of dementias, it is frontal temporal, which is also where schizophrenia hangs out. There's 3 variants of it, but just say in general, here's the take-home pieces. The thing that goes first is empathy. So what? Who cares? If you lose empathy, your family's going to kill you. They're going to leave you. So this is the person who's 60, 70, has a family gathering, Thanksgiving, and starts saying to her son, you know, your wife, she's such a bitch. You know, she's fat, she's stupid. What the hell did you ever marry her? At Thanksgiving dinner. And the son's like, Mom. Now, everybody at the dinner might think that all those things are true, but obviously they just say them. After the dinner, the son will go up and say, Mom, I can't believe you did that to my wife. You need to apologize. What? What is true? No empathy, nothing. Gone. Goes.
It's not delusional. It's just
no. It's not a delusion. It's absolutely true. The screen goes. The screen is gone. There's no empathy. She has no regard for the feelings of the other person. Now, just an interesting little tidbit. Last year, students entering freshman year of college get this survey that, I don't know, the American Psychiatric Association, somebody sends out, or colleges just agree to give it. I don't know how it goes. Anyway, the survey they do every year. And what they found last year is that freshmen entering college, so they're 18, have 40% less empathy than freshmen entering college 10 years previously. 40% less empathy in the generation entering college now. So, we are going to have an awesome culture. These are my caregivers. If you don't have empathy, how do you care for someone that's just been incontinent? If you don't have the ability to say, but for the grace of God go I, let me help you. You must be so embarrassed. Let me be your care partner. Let me help you. If you don't have that ability, it makes it very hard to be in healthcare. So we're going to really struggle with this group. And they think it's, social media, and you text, and you send out Facebook posts, and you say all this horrid stuff. Because in high school, remember, we really did say nasty things about each other, and there was cliques, and everybody, looks like a slut today, and he looks, but we said it, and we saw people's responses in real time. And a little part of me felt like, oh, that wasn't good. I hurt her feelings. Even if we're laughing with the group, we know we're hurting their feelings because we can see it. But if it's all on social media, you don't see the response of your remarks, so you don't develop a healthy amount of empathy. So,
and all the violence that they see on TV and media is a desensitizing thing too.
Yeah. So it's just a nice little nugget of fascinating information for me. But if you're struggling with caregivers and you have to hire them, it's hard. I've been trying to work with 2 psychologist peeps to come in and do some teaching to teach empathy, which is not sure it's teachable or if it's developmental. There is now, because of this issue, there are people and social workers and psychologists really working on how to help people develop empathy. Hopefully we can do it. So empathy goes away, so their family hates them. Then you start seeing some of the cognitive problems. Then you start seeing some of the memory problems. They also develop this little OCD, I call it, obsessive compulsive. Now sometimes it's lovely. I had one woman who had a pug actually, and it was a fawn pug. And my pug, you can see, weighs about 15 pounds. This pug weighed 40 pounds. And Henry, I gotta find Henry. Where's Henry? Where's Henry? Right on your lap, right here. Oh no. Oh, okay. Have you seen Henry? I gotta find Henry. Where's Henry? You gotta be with Henry. You gotta keep Henry. Where's Henry? Every waking moment, unless there was food in her mouth, or she was in the shower, was about Henry. And even in the shower, if she wanted Henry there, she gotta find Henry. Henry's gotta be there. For 2 years of poor Henry. She finally passed away. Family took Henry and sent us a picture a year later. Henry had lost like 20 pounds. One woman that we have now has to have noise, that she has to clap, she has to hold her hand and she has to stand. Door handles, bang, 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 bang. Forks, knives. Has to be removed from the home, put in the beauty shop, one-on-one at all meal times, because they'll plow her. I can't keep them away from wanting to hurt her, because she's so annoying. There's no stopping it. You can give every drug under the sun. Predisposing is really mini-cress. It's a blood pressure med. I've been trying to work with that. You've got to take it way up to like 18 milligrams a day or some crazy amount. And if they don't die of hypotension and they're still moving, and you add a huge dose of antipsychotic, like 15 milligrams of Zyprexa. I use 2.5 on a good day. Huge amounts because their brain is inundated with whatever it is. They're really hard. Most care communities evict them because they're so disruptive, and there's not gods you can do. All right, Alzheimer's is Energizer Bunny, vascular, couch potato, Lewy body. Lewy body is nice. Psych. Usually they're going to have hallucinations, delusions, and functional problems early on. By the time you get to a care community, they have adaptive equipment. They're going to learn to use a walker and wheelchair early. They're going to use it. Alzheimer's, when they start falling end stage, they can't use a walker. They'll carry it. Pull it behind them. You can put them in Mary walkers, work great, because they have to move. They have to move, but their legs don't work. So they're up, down, up, down. The Mary walkers, you know, the little PVC type things. I think we have a corral of them. We have like 20 or something now. They're going to move. I can't tie them down anymore. Gone are those days. Even can't do anything. They have to walk. So just put them in some device that allows them to walk. And the Mary walkers, once they adapt, it takes like a couple days. Some people love them the minute. You try it, wait another month, try it again, and then they're ready. And they feel completely independent, which is really awesome. Questions on types?
Just the drug. Here you put on the Lewy body, you shouldn't use Seroquel.
Did I say it wrong?
Well, it says antipsychotics.
Oh, except antipsychotics. No way change that. Only Seroquel.
Okay.
Typo. Yeah.
Is the prevalence of these cognitive disorders, is it the same or globally in every country?
All countries get the same dementias that Americans do. No, we are unique. No. Some countries don't get old. The average age of death, like in India or Africa or something, is still 60s. So they don't have as much of the prevalence of Alzheimer's, because Alzheimer's is really a later life disease. There's early onset Alzheimer's that comes in your 50s. It's like 3 or 5%. Most Alzheimer's starts in your mid-60s later. So because of that age difference, it's different in different countries. And I don't know if there's enough data on all the countries for exactly how much Alzheimer's, vascular, Lewy body, because still the world says dementia. So
What about percentages in other Western countries, just in terms
we're
of
like Europe.
dementia?
We're like Europe.
So they have the same rates of dementia as
Yep.
we do.
They have if I had to guess, well, no, it's not true. I thought maybe a little bit less vascular, but they actually have some higher heart attacks than we do in Scandinavia, which is kind of weird. But they eat a lot of cheese and milk.
I saw a special on television, I don't know, a couple of months ago, and they had been studying this group of nuns, I don't remember.
Oh, the nuns story, yeah.
Yeah. And they were still very functional in teaching and their roles, and so they thought that for whatever reason they weren't getting dementia, but when they did the autopsy and autopsied the brain, they had dementia.
Oh.
Like our country does, but can you address that?
Well, so the nun study I was thinking of is the one that they looked at women entering the nunnery young, like in 15 or 16, and they watched them longitudinally, or they actually went back and looked at handwriting. And the nuns that had decent handwriting, had nice penmanship when they were 15, 16, 17, 20s, were less likely to develop Alzheimer's than nuns that had horrible handwriting early on. That's going to be harder to do because there are many types now, but if you autopsy everybody's brain, there are beta amyloid plaques in all of us. There's probably some neurofibrillary tangles, and some people get Alzheimer's early. Probably they have less brain function available to them than college professors or whatever, but you can still get it if you live long enough. So I don't know how long those nuns lived. When they do studies on Alzheimer's for the beta amyloid plaques, the studies that came out that we're all excited about is they eliminated the plaques. They got rid of them in the brain with these medications. It did not correlate with improved cognitive function. So even though we know they develop with Alzheimer's, they probably develop with aging too. And some people they affect and some people they don't affect. There's more to come as we get smarter.
I just have one more question. So as far as heredity, these cognitive disorders, how...
So the only heredity thing that we really know about is Alzheimer's, and a subsection of Alzheimer's has a strong familial heredity. So there's one population in South America that we do a lot of studies on that, they have the gene. We know exactly what gene it is. They got it. They're getting it. They're getting it in their 40s and 50s. That's a tiny number of people. So you can get a genetic test. But if your mom didn't have it, don't even bother. Your mom and dad didn't have it, don't bother getting that test. Because mostly it's a later life phenomenon.
So is that, I was reading about that group of people. So are you trying to determine whether gene-environment interaction is important in this subject? Like schizophrenia?
Oh, they're looking at everything. They're doing so many studies with that group.
Do you know whether or not the
No one knows.
environment kind of disables
Nope,
it?
nope. No, we don't know if it's diet, environment, genes, just life expectancy, flip of the diet. No one really knows why some people get Alzheimer's and some don't. But if you live long enough, your likelihood is almost 1 in 5, 2 in 5 in your 90s. I mean, it's just huge. You probably will get it. All right, tool 2, rule out delirium. This one's easy. First, normal aging. We kind of went through all those sensory changes and things. They're confusing. Depression will fool you. So we call it a pseudo-dementia. You have to make sure someone isn't depressed, because if you have a sedentary type depression where you want to sleep all the time, you don't want to do anything, your favorite word is no, you're a teenager, you just hate everybody in the world, they get that kind of depression. So do old peeps. They'll respond to most of the tests, most of the questions on the cognitive screening test with, I don't know, no. So they'll fail it, and they'll look like they're demented, but you treat their depression, and lo and behold, they're cognitively right there with you. There's a lot of reasons old people get depressed. Health, loss of significant others, loss of friends, downsizing, relocating, retirement, a million reasons. Pretty much everybody over the age of 65 probably should be on an antidepressant. All right, we're going to play a game here, so you got to write in the answers. What dementia is now. So delirium, I came up with this little mnemonic called confusion. Is that good? Come on. So, whether you're demented or not, if you're old and you have a change in mental status, there's a reason. So you can have a nice, happy, friendly Alzheimer patient in your community, and then all of a sudden they're beating the crap out of everybody and being really resistive and whatever. It's not their Alzheimer's. It's something else that's caused that change in their normal behavior. Caregivers know the normal behavior of whatever their residents are. I mean, it can be weird stuff, but that's normal for them. They can always take their clothes off. They can always crawl under the table. They can always be the ones that sit there and do nothing. If that changes, there's a reason. If you're just elderly, And suddenly, people are saying, God, she's so confused. She's acting weird. You don't just have sudden onset Alzheimer's or sudden onset vascular. You're sick. So the problem with the aging brain is it has less reserve to deal with medical instability. The first thing that goes for bladder infection or for other change in physiology is a change in mental status. So you have to be little Sherlock Holmeses and figure out what it is in your residence before you get all up in arms and think things are going wacky. And so what we're going to do is go through this.